All right, so now for the fireworks. Let's have Dr. Yip, Moghanaki, and Dr. Altorki come up for discussion. And starting from Dr. Altorki's point about a randomized trial is what's needed, let me ask you a question. Dr. Altorki, Dr. Moghanaki, Dr. Yip, if we have a 50-year-old healthy patient with a 1.5 centimeter adenocarcinoma, would you enroll that patient in a randomized controlled trial, Dr. Altorki?
What size?
1.5.
A randomized trial of SBRT versus surgery?
SBRT versus surgery. Would you enroll that patient?
I would definitely discuss the trial with the patient if we have it open. I mean, the patient has a right to know that there is a trial comparing the two.
Would you participate in a trial like that? Let's say 1 centimeter. Would you participate in that trial?
I think I would, yeah.
It doesn't sound too definitive there.
Well,
You
it
hesitate.
is not definitive because it's a tough decision and I'm thinking about it. And but I do think that it is a question that needs to be answered because, things are bubbling from the bottom up that, SBRT is good. And I don't disagree with that for patients who are high risk, but I think it's not proven to be good in patients with operable otherwise for this kind of patient. So we need to answer the question. If the patient is willing to participate, then the patient is willing to participate.
So Dr. Moghanaki, a different spin on this. Same patient happens to be your mom, has a 1.5 centimeter lesion. Would you enroll her in the clinical trial of SBRT versus surgery?
You didn't ask me that question.
Okay, if it's your mom then.
Yeah, let's pretend you asked me. The answer is no.
So Dr. Moghanaki, what would you do with that patient?
So David Harpole and I both feel that we would never enroll a patient into this study if we ourselves, I mean, I love my mom, my dad, but I might love myself more. I don't know. And so, the study ultimately requires 2 checkboxes. Would the surgeon do a lobe or a segment? All they have to say is yes or no. It was actually the FDA that required us to set a minimum FEV1 and DLCO pre-op 40% boundary. We trusted the surgeon's judgment. And then second, the radiation oncologists must also agree that they would do it. So that's how the study is designed. If I have a right upper lobe lesion right next to the SA node and the patient's operable, I wouldn't SBRT that patient on trial or off trial. If that tumor was in the left side, right at the proximal LAD, same thing. I would not SBRT a lesion in that location. So I really believe that on the back end of the study, and also as is happening on this study, that the anatomic location and considerations of the patient's comorbidity will be weighed when both treatments are equally considered. And one of the things that I would in the interest of time, I didn't show that updated revised STARS trial at MD Anderson of patients treated with either SBRT or surgery at MD Anderson showed a grade 3 rate of 1% in the SABRE group and 50% in the surgery group. So I would lean towards surgery knowing, and I have very healthy conversations in the MDT and with my patients. I'm often asked by my surgeons to talk to the patient about surgery because they don't want surgery. And so I'm on the same team as a surgeon again, and back to that, when I think that SBRT isn't a good option. So age alone is insufficient. I was just talking to Nasser earlier. I have a patient in her late 50s right now, but it's peripheral, it's high up, it's nowhere near the brachial plexus, it's nowhere near the esophagus of the heart. I'm very comfortable for that patient. But if it's in a dangerous location, I will push for surgery, even if the patient's moderate to high risk.
So you brought something up that I haven't heard our radiation oncologist bring up. You mentioned the SA node and the LAD. Can you expand on that? What are you concerned about when you're giving radiation?
Well, the sine qua non of radiation injury is normal tissue atrophy. And we're also learning that it may affect cardiac conduction. So there's at least one publication from Stanford where patient did go into bradycardia after SBRT, and they published a really nice paper that, first of all, tells us where the SA node is. I don't think radiation oncologists have ever thought about it. And then second, showed the doses of where it went. Now, they had other cases where it had gotten some dose and it was okay. So the question is, was it coincidental or not? But for me, that's sufficient to do no harm. And then regarding the proximal left anterior descending artery coming off the aortic root, you know, I often am talking to my interventional radiologist when surgery is off the table. Can you induce a pneumothorax, get it away, and freeze it or microwave it instead of SBRTing it? Because if the patient's got 10 years to live, I don't know what's going to happen to that coronary artery. And we know that cardiac events can occur after radiation that incidentally exposes the heart.
And Dr. Yip, so understanding that you're a biostatistician rather than a medical doctor, from the statistics that you see, if you had a family member who was 40 years old with a 1.5 centimeter lesion, based on the data you have, would you enroll them in this randomized trial, or would you just have them go to surgery, or would you just have them have radiation? I love putting her on the spot. Can we make a decision based on numbers alone? If we take, because the doctors, the surgeons, like Nasser showed, the radiation oncologists, we're all biased because this is what we treat every day. So from a pure numbers standpoint, is there equipoise?
I think I would just probably tell my parents to get second opinion, third opinion, and accompany them to the clinic and try to get more information instead of making the decision for them.
I just want to say something about Rowena's presentation, which was great. There is a difference between screen detected lung cancers and cancers like are detected in routine clinical care. We saw what David showed. The patient has a nodule in the lung that was there for 3 years. And, you know, it's not unreasonable to ask, how does the no treatment arm do in that comparison? I mean, these are, they move at a pretty slow pace. Now, that is not to say that at some point during the biology or the lifetime of that cancer, something changes and the pace of growth kicks up a lot. So it's different, and I think we should not commingle lung cancer screening detected patients with the other ones. The point I would like to make is this thing about radiofrequency ablation. We think of all these as equivalent local therapies. There is a trial called the Rapture trial, which you can look up, which shows that radiofrequency ablation for primary lung cancer was associated with a 30% local failure rate within 12 months. It was good for colorectal mets, but not for primary lung cancer. And this is like a serious problem here.
So I think this brings up, you know, a huge area of uncertainty, and, you know, having a no treatment arm is important because biology plays more of a role, I think, than either surgery or SBRT. And so,
It's a question.
oh, yes.
Thank you. I've been enjoying the sessions. I think one common blind spot that perhaps we are not putting into the equation is the key element, as in if you buy a property, the key decision making is location, location, location. Proximity to SA node, coronary arteries, where the location, peripheral versus central, are key to the ultimate decision. Put aside the patient's preference. I think the absent element here that the entire group should factor in is try to figure out how we can position a location parameter into our quantification so that it can add on precision to the discussion. Thank you.
Yeah, I think that's an excellent point. The location is a big, big point. But then that brings up the other things, body habitus, comorbidities. It's multifactorial when you're looking at a patient, but location is huge. So I think we're going to take a coffee break and then we're going to come back and review some cases with Dr. Y.